Since 2023. In point of fact, these are not guidelines. It's just an update of the guidelines presented in 2021. But in heart failure, there is so many news that, as you know, guidelines, they are normally published every 4 years. And it took just 2 years to update these guidelines to try to incorporate all what was going on. So I will try to summarize what was more important in this update. Number one, SGLT2 inhibitors. The appearance of emperor-preserved and delivered in the last 2 years has changed the indications of SGLT2 inhibitors. In the 2021, it was a clear type 1 indication in HFrEF. Here we have a type 1 indication for DAPA and empagliflozin in HFmREF in mildly reduced, which is 40 to 49% ejection fraction, and diuretics for fluid retention, also class 1. ACE, ARNI, ARBs, MRAs, and beta blockers, they remain as class 2Bs because all of those are sub-analysis from previous studies. This is how it reads in the guidelines. An SGLT2 inhibitor, DAPA or EMPA, is recommended in HFmREF to reduce heart failure hospitalizations or death. 1A, in a way saying that it is mandatory, but even more important in HFpEF. So in HFpEF, DAPA and EMPA, also class 1 with diuretics, and also consider, very important, treatment of etiology, cardiovascular and non-cardiovascular comorbidities. So now in HFpEF, we need to put the fundamental treatment, which is DAPA, EMPA, or diuretics, and then look for obesity, hypertension, diabetes, AFib, COPD, and all the other comorbidities that are associated with HFpEF. Recommendation, the same to reduce heart failure hospitalization, CV death, 1A. So now we have 1A SGLT2 inhibitors across the spectrum of ejection fraction. So we have the 2021 ESC guideline, the 2022 American College guidelines with a 1A indication for HFrEF. We have the 2023 guidelines indication 1A for HFmREF and HFpEF. So SGLT2 inhibitors appear to be a treatment that should be started regardless of ejection fraction. And I would just suggest that we should all be more proactive uncovering these patients with heart failure, because these trials with SGLT2 inhibitors show that the benefit appeared as early as 15 days. So we cannot wait months and months to make the diagnosis, so we should be, we make this diagnosis much earlier. And this is exactly what this slide is telling you. So in the emperor reduced, you see that statistical significance was reached after 12 days. In emperor preserved, it reached after 18 days. So you just need 2 to 3 weeks to get benefit. So we need to start treating our patients with these drugs. So it appears that there is enough evidence also in these patients to treat diabetic patients with CKD with SGLT2 inhibitors to prevent the risk of heart failure hospitalization of death, also with a 1A indication. And for the first time, it appears the word finerenone. Finerenone is this new MRA. There are 2 trials, Fidelio DKD, Figaro DKD, and finerenone is recommended in patients with type 2 to reduce the risk of heart failure with an indication 1A. So we will hear more about finerenone, but here it is in the guidelines already. I think it's very interesting what happens here with this recommendation. This is a pragmatic recommendation. Here they are not, the guidelines are not recommending us any specific drug or device. They are recommending us to do a pragmatic approach, which is intensive treatment in patients admitted with heart failure. So an intensive strategy of initiation and rapid up-titration of GDMT before discharge and during frequent and careful follow-up during the first 6 weeks is recommended. So for the first time, the guidelines tell us, please start the treatment in the hospital admission and follow after the hospital admission. And this is thanks to our good friend Alex Mevaza, who did the strong HF trial. As you can see here, randomized high intensity versus usual care, introducing the GDMT in hospital, and then following at week 1, 2, 3, 4, 5, and 6. Up titration of drugs, searching for safety versus standard of care, 90-day follow-up, 180-day endpoint of heart failure readmission or all-cause mortality. This trial was terminated prematurely because of excess benefit. Nobody was anticipating an excess benefit, but this is what happened after 1,000 patients. And this is what was going on. In the RASI group, you can see that this dark red is full dose, brighter red is half dose. So 90 days and 180 days, more than 80% of patients with RASI, 30 to 40 in the usual care. In the beta blocker group, as you can see here, more than 80% of patients treated with beta blockers. In the intensive care group, just 30 to 40 in the standard of care. And very interestingly, the MRA group was very similar between standard of care and intensive care, all of them over 90%. So it looks like there is a much more uptake of RASI and beta blockers, and this translates into better outcomes. The primary outcome is readmission for heart failure or all-cause death, and this was statistically significant. When looking at the secondary endpoints or components of the primary endpoint, it appears that all-cause death was non-significant, so it looks like the major benefit we can get is from reducing heart failure hospitalizations. Iron deficiency is catching up in the guidelines after so many years, and this is the recommendation. 1A recommendation of iron, IV iron to improve symptoms and quality of life. 2AA recommendation of IV iron to reduce the risk of heart failure hospitalization. So 1A to improve symptoms in REF and MREF, 2A to reduce the risk. There are a number of trials. You all know that iron deficiency is prevalent. 55% of patients with chronic heart failure have iron deficiency. 80% of patients with acute heart failure have iron deficiency. So we should not overlook iron deficiency no more. And there is this meta-analysis, this Bayesian meta-analysis published by Stefan Anker just a few months ago before the guidelines, which analyzed the 4 trials that we have today: FAIR-HF, CONFIRM-HF, AFFIRM-HF, Ironman. The first 3 is with ferric carboxymaltose. The last one is with ferric derisomaldose. They had individual patient data for the first 3 and study level data for the 4th. Which was the outcomes of this meta-analysis? In the forest plot of the overall trials, of the 4 trials, it was statistically significantly favorable for IV iron, so that was very clear. Nevertheless, the predicted treatment effect in future trials with the Bayesian 95% prediction interval, which is a novel statistic to identify what may happen in a future trial, was not so clear. And it suggested that uncertainty is still present in the field of iron deficiency treatment in patients with HFrEF. And this is exactly what happened. So when the guidelines were published with these recommendations, a few hours later, this study, the HEART-FIT, was published in the New England Journal of Medicine. Ferric carboxymaltose in heart failure with iron deficiency. Results. Among ambulatory patients with HFrEF and iron deficiency, there is no difference between ferric carboxymaltose and placebo with respect to the hierarchical composite of death, hospitalizations, or 6 minutes walk distance. So the updates of the guidelines were published 2 weeks ago, and after they are published, they are already outdated with this trial. So science goes very quickly, and it's a fascinating time for heart failure. Thank you very much.